Good afternoon. My name is Mary Lou Gorno. I am second vice chair of the Economic Club of Chicago. We are delighted to welcome everyone to this virtual program. We have convened a distinguished panel to discuss COVID-19 and current research developments. We are showcasing the Lewis A. Simpson and Kimberly K. Querrey Biomedical Research Center, located on the downtown Chicago campus of Northwestern University. While we wish we could tour the state-of-the-art research facility in person today, we are grateful to be able to hear from leading scholars about the work that they are doing. Today, we are fortunate to have Dr. Eric Neilson to moderate the conversation. Dr. Neilson is the Dean of Northwestern University Feinberg School of Medicine and a long-standing member of the Economic Club. For today's program, Dr. Neilson will introduce each of the panelists. They will then give brief remarks, followed by live questions from the audience. Please submit your questions using the Q&A tab on Zoom. I will now turn it over to Dr. Neilson. Thank you.
Thank you, Mary Lou. And we're really delighted today to be part of this different kind of fifth night. We're very sorry you can't join us down in Streeterville in this beautiful building. We decided, because we couldn't be physically present down here, that we would show you a brief video first of the building so you get a chance to see what a spectacular addition it is to the Chicago campus and to Chicago as a national leader in healthcare. So we're going to hear the video first, and I think we're all ready. Thank you. I would love to take any of you on a tour once we are no longer sheltering in place and can receive visitors at this beautiful new addition to the Chicago skyline. And we're ready now to begin our program. We decided recently to elevate the program to discuss COVID-19 in Chicago. And we put together a distinguished group of panelists who will talk about various aspects of it. Each of the panelists will talk for about 5 minutes. And then at the conclusion of that, we will open it up for questions and hopefully engage everybody in an interesting discussion of where things are today with the COVID virus. Our first panelist is Dr. Gary Noskin. He's a Senior Vice President for Quality at Northwestern Memorial Healthcare. He's the Chief Medical Officer at Northwestern Memorial Hospital and a Professor of Infectious Disease at Feinberg. Gary, please tell us a little bit about the current status of COVID-19 in Chicago.
Thank you, Dr. Neilson, and good afternoon. It's great to have so many participants on the call this afternoon. And thank you for your leadership in Chicago's business and civic communities, as well as the invitation for me to briefly discuss COVID-19 in the city of Chicago. COVID-19 is a disease caused by the SARS-CoV-2 virus. And despite the impact of this pandemic in both the city and the state, there's really been unprecedented collaboration among our universities and healthcare system to understand the epidemiology of this virus, but also to care for those who are infected. The clinical picture for COVID-19 is not completely known, but the reported illnesses include things that are relatively mild to those which are severe and potentially life-threatening. The majority of individuals with COVID have a mild infection that we manage in the outpatient environment. However, about 15% of patients require hospitalization and 5% require care in intensive care unit. The majority of people who do not survive this infection are older adults, mainly those over the age of 65, although individuals over the age of 80 are at highest risk for an adverse outcome. We also know that there are several underlying medical conditions that predispose patients to COVID, as well as an adverse outcome, and that includes high blood pressure, diabetes, and heart disease. We're also starting to identify an increase in infections in congregate settings, so nursing homes, long-term care facilities, and then most recently the jail. The virus is primarily spread from person to person, especially those who are in close contact less than 6 feet. We're learning a great deal about the clinical manifestations of COVID, but again, it does remain in evolution. The incubation period for this virus is 2 to 14 days, with the median being 5 to 7 days. The clinical symptoms are most commonly fever, chills, cough, shortness of breath. But interestingly, we're finding things such as nausea, vomiting, diarrhea, also suggesting COVID. And the sudden onset of loss of taste or smell has now been reported in about 15% of individuals. Within the state of Illinois, we've had a little bit more than 96,000 individuals who've acquired this infection and about 4,200 deaths. The experience here in Chicago is similar to that in the rest of the country, with an increased incidence of infections in Black and Latinx individuals. The governor has recently released his 5-phase plan to restore Illinois. Currently, we're in phase 2, or the flattening phase. And according to the models used by the state, the current stay-at-home order has been really successful in flattening the curve, as well as slowing down the rate of transmission. At present, we have enough hospital, ICU, and ventilators in order to care for patients with COVID in Chicago. Currently, all 4 regions within the state are on pace to move to the next phase. So we would anticipate when the current stay-at-home order ends at the end of the month, we'll be able to move to phase 3. I also wanted to briefly mention the role of masks. As of May 1st, all Illinois residents should be wearing a mask or a face covering whenever they're leaving their home and reporting for work. And this guidance is particularly important in individuals who are unable to maintain a physical distance of 6 feet. With increasing activity over the next several weeks, it's really important that we remind our friends and colleagues of this requirement. With regards to treatment, there's currently no FDA-approved treatment for COVID. However, there's multiple different treatment regimens that have been explored. You may have heard early about the role of hydroxychloroquine, either alone or in combination with azithromycin. It turns out this regimen doesn't work, and in some patients may actually be associated with a worse outcome. More recently, there's a drug called remdesivir. Remdesivir was initially developed for the treatment of Ebola. It doesn't particularly work for Ebola, but it does have activity against a lot of other viruses, including the SARS-CoV virus. The FDA granted emergency use authorization to the use of remdesivir for specific indications, and the drug has clearly been shown to have a modest improvement in mortality, but a significant reduction in duration of symptoms. Several people have asked about the role of convalescent serum, that is obtaining serum from individuals who've actually recovered from COVID, and there are ongoing clinical trials at multiple hospitals throughout Chicago exploring that option. I think the most important for all of us to think about is the best way to prevent this infection is to prevent exposure to the virus. And there's actually 5 things that we can do to do that. First is to maintain a physical distance of at least 6 feet. Second would be to wash your hands frequently with soap and water. If soap and water isn't available, then an alcohol-based hand hygiene product that's at least 60% alcohol. Avoid touching your face, especially with unwashed hands. Clean and disinfect surfaces, especially those that are high touch, frequently. And finally, it's important to wear a mask. So again, thank you for joining us on the call this afternoon, and I'm going to turn it back to Dr. Neilson.
Thank you, Gary. Our next panelist is Dr. Howard Chrisman. He's president of the Northwestern Medical Group, Senior Vice President for Northwestern Memorial Healthcare, and a professor of radiology and surgery at Feinberg. Howard is going to tell us a little bit about how we're thinking about getting regular healthcare back on track in Chicago.
Thank you, Dr. Neilson, and thank you to those in the audience for your leadership. On March 21st, Governor Pritzker announced his stay-at-home order in response to the unprecedented pandemic that we're facing as a nation. Healthcare systems throughout Chicago responded. Northwestern Medicine's response, after preparation and acknowledging the sweeping policy changes, was swift and decisive. Our daily occupancy of licensed bed, which was typically at 96%, dropped to 47%, and over 7,500 surgeries and procedures were postponed for us to adequately treat the COVID-19 population we anticipated. We acquired PPE or masks from around the world to ensure our staff was safe, and our research partners began important clinical trials. To date, our nurses, physicians, and those that support our caregivers has been spectacular, treating over 5,000 COVID-19 patients with a mortality rate of approximately 5.2%. So as we think about reactivating care, we have a clear and guiding principle of creating a safe and trusted environment. We understand that our physicians, nurses, and others that provide care have to be comfortable in their environment in order for our patients to feel comfortable to return to care. So following guidance by national and public health authorities, we've instituted a number of following safety prioritizations. We've put in place screening, so all individuals that enter our facilities are screened for temperature, screened for any symptoms, and screened for any contact. We require individuals must wear masks at all time, maintain physical distancing. We are testing all patients prior to certain procedures and surgeries. And hand hygiene, as Dr. Noskin mentions, is foundational. We've also worked with our facility leadership to be able to create environments that are appropriate. So we've modified seating plans in waiting areas. We've addressed physical distancing in our clinics, and we monitor certain environments that have high traffic or common areas like our elevators. We developed playbooks for reactivation that include best practices in our ambulatory or clinic environments, our surgical areas, procedural areas, and diagnostic areas. We know this is a marathon, not a sprint, so we spend a lot of time thinking about our staff wellness and supporting their overall physical and mental well-being. Effective communication is integral to what we do. Throughout the response and reactant phases, we have hosted over 100 virtual meetings to our physicians, leadership, and other stakeholders. We have directly communicated with our patients. We have a patient-centered video, and we have a trusted website that provides information and resources with over 50,000 visitors a day. As we think about reactivation, and we recognize that the governor's work at home or shelter in place has been extended through the end of May, certain procedures were permitted under guidelines starting May 11th, so this past Monday. Our approach has been to utilize the same system we use to postpone cases to prioritize them for reactivation. So they fall into three categories. Category A are emergent procedures. These are the types of procedures such as trauma that we've been treating throughout the pandemic and will continue to treat. Category B are cases that are urgent that can no longer wait. So think, for example, cancer surgeries. And category C are those types of procedures that if we continue to further delay might result in progression of disease. So for example, cataract surgery. So this past week, as per IDPH guidelines, we began treating these patients after prioritizing them. This has been very well received by our physicians, by their families, and the patients themselves. We've seen about a 25% increase compared to the previous week. And although this is only 30% of our volume, it has really been very gratefully received by all who have participated. At the same time, we have also treated patients in our outpatient clinics or our ambulatory environments. What's been really interesting through the pandemic is the adoption of technology. So about 60% of our patients are now treated via telehealth, either through telephonic or video means. Prior to this, it was at about 10%. So we believe telehealth is here to stay. Also, we recognize, however, that there is still a need for patients to be seen in person. And so these past few weeks, we are seeing increasing numbers of patients with chronic illnesses or other needs to be seen in person. So in summary, we're all in this together. As Gary mentioned, things like hand hygiene, masking, physical distancing, environmental awareness, perhaps some added patience as it will take longer to catch up on the backlog and take a bit longer to get from point A to point B will be required. And one thing that I thought I would do is take 1 minute to just tell a story, which I think encapsulates the types of individuals that we are working with in our environment and across healthcare. It's about some of our unit nurses. There's a nurse called Raquel Colento that many of us know, who is age 63 and takes care of her 91-year-old mother. And so when the COVID-19 population began to arrive at Northwestern Memorial Hospital, she was offered the opportunity to switch to a different department or a different ICU. But she thought about the young nurses in the unit, the ones that called her mom, and they were so full of energy and compassion that she decided to stay with them as part of the team. So there's a group of these ICU nurses that are in their 50s and older who are already legendary at Northwestern before the COVID-19 struck. But in the days that followed, the 10 who remained in the ICU after 30 years or more have continued to care for amongst the sickest patients in the city, despite being an age, as Gary mentioned, that puts them at added risk. One of the younger nurses, Catherine Glazer, reflected, "I feel like they're such a symbol of hope. It's difficult going to work and not knowing what you're going to face that day. So having them there, being able to really fall back on them is really nice." Another nurse, Cindy Pascala, grew up with the environment with everyone there from her 20s, 30s, 40s, and 50s. She reflected that when she comes to work with dozens of COVID patients as part of a rapid response team, she feels safe. She said, because staff members are following safety guidelines and wearing recommended protective gear. And now more than ever, being a nurse feels like a calling, she said. Her young coworkers have canceled their time off or come to work after the pandemic led them to postpone their weddings. Everyone is in the unit right now. I think that keeps me going to see these kids that are really willing to help out. So I think that captures the types of individuals we are working with. And thank you, Dr. Neilson.
Thank you, Howard. Our last panelist is Dr. Richard D'Aquila, the Howard Taylor Ricketts Professor of Infectious Diseases. He's the Senior Associate Dean for Clinical and Translational Research and Associate Vice President for Research at Northwestern University. Rich is going to tell us a little bit about the latest on vaccine development and serologic testing.
Thank you, Eric. It's a pleasure to be here today. I'm going to give you a state of the art as of this morning. The search for a vaccine for SARS-CoV-2 to protect people from getting infected or potentially reinfected has gotten off to a great start, but there's only partial information, and there's a lot more we need to learn. The goal is to put a piece of the virus into the body in a way that the body can generate immune defenses against it. We think from experience with lots of other respiratory viruses that the most important defense is a particular type of antibody. Antibodies come in many flavors, but one called a neutralizing antibody, we think, can bind to the virus and prevent it from entering a human cell, and thereby hopefully either prevent infection completely or at least keep the infection mild enough so that it doesn't cause the severe disease that Gary's described. There are currently 8 vaccine candidates using different types of delivery of pieces of the virus. There are 8 that are in clinical trials now. I'll tell you about 2 of them. There are another 110 that are in preclinical development, and some will start entering clinical trials in the summer or fall. In particular, there are a couple, one from Janssen, which mimics a successful vaccine for Ebola that they developed, and another from Sanofi GSK that is based on delivering a piece of the protein of the virus, which has been successful for hepatitis and other infections. But the 2 that are in the news are very different platforms or ways of delivering a piece of the virus that really have never been used before. You've all heard, I think, about the Moderna vaccine candidate. It's an RNA called mRNA 1273. They're collaborating with the National Institutes of Health and a company called Lonza will help them with manufacturing. It's been fast-tracked by the FDA. BARDA at the NIH has awarded almost $500 million to manufacture it. The trials are well along. We heard yesterday a press release about very partial results of their phase 1 trial in 45 people, I'm sorry. This is taking place in Seattle. And the news was good. They reported that of the people that have been tested so far, all developed antibodies at levels similar to those in patients who recovered. And of note, they only had data from 8 of the 30 where they had antibody testing done, and the 8 that were checked for neutralizing antibodies had them. And that's very promising. They're moving into larger trials, starting with about 600 patients, and they are shooting for getting approval and beginning to distribute it in early 2021. The second candidate that's been in the news is from Oxford and the Jenner Institute, and they're partnering with AstraZeneca. Those trials are all going on in the UK. And it is a very different kind of vaccine. It uses a virus that's crippled and can't replicate. It's a chimp adenovirus, and they're using that because earlier attempts to use human adenoviruses to deliver pieces of another virus led to some problems that I'll tell you about in a minute. And they hope that by having a virus that no human has been exposed to, because it's only in chimps, should prevent those bad side effects from happening. So they have reported just end of last week that in 6 monkeys that they vaccinated, they were all protected from getting pneumonia after a challenge with the virus about 2 months after vaccination. They did get infected, but none of them had pneumonia, and all the control monkeys did get a bad pneumonia. I think the instructive thing from both these studies so far is that none of the bad problems that have prevented us from getting a vaccine against HIV or RSV for more than 30 years appear to have happened yet. It's very early, but the worry is that sometimes vaccines can make antibodies which actually make the virus better able to enter human cells and makes the likelihood of catching an infection worse. This has happened as a result of trying an adenovirus vectored vaccine for HIV, where people who had previous immunity to adenovirus had their immune system stimulated and had a higher risk of catching HIV after being vaccinated. The other thing that's happened in the past, this was going back to the 60s, when whole inactivated virus was tried as a vaccine for RSV and for measles, is in children, this can cause accelerated respiratory disease. It can make a pneumonia instead of the virus causing the pneumonia, the vaccine can do that. And there are specific immune mechanisms that cause that. And we have not seen any of those immune mechanisms in the 2 trials that I told you about so far. So it's early, but things are good. And the hope is that as these progress, we'll also have quicker ways of measuring these neutralizing antibodies. Right now, this requires a very difficult laboratory technique, and it requires what's called a biosafety level 3 laboratory with much greater containment than is available in most laboratories. But there are people working, and already one paper published, on making that into a much simpler test that can be hopefully able to monitor if people who've recovered are protected, and we can monitor who could get priority for vaccination. We could follow how long the antibodies that neutralize last, so we would know if there's a need for revaccination or not. So I'll stop there. Thank you for your attention.
Thanks, Rich. Maybe you could first comment on what's going on in the area of serologic testing in the city, and what is the plan? How are we going to use that information?
We've got a long way to go. The market has been flooded with all kinds of antibody tests, mostly point of care qualitative tests. They are of very, I should say, poor quality for the most part. There are better tests that are coming online that detect the total amount of antibodies. But again, what we'd like to detect are the neutralizing antibodies. And we don't yet have a way to do that at scale. It can only be done on very small numbers of samples. The NIH is doing that to try to look at the convalescent plasma that Gary mentioned is being given to patients. But that's all being done retrospectively because it's so hard to measure. So they hope they'll be able to make a correlation with whether there's enough antibody and whether that convalescent plasma actually helps someone get better or not. But that's going to have to be done after the fact. So antibody testing has a very long way to go. It has no role in acutely diagnosing the infection, but it will tell you if there's been exposure. So it'll be useful for measuring the prevalence of infection because there's been a lot of asymptomatic spread. But again, the testing is not quite ready for prime time to even do that yet.
Well, thanks. Thank you very much, Rick. We have a lot of questions, so we'll try and get through them as quickly as we can. Gary, first question is, if we're flattening the curve, why are the case numbers continuing to rise in Illinois?
So there's a couple things that we should look at. There's the absolute number of cases as well as the rate of positive infections. So obviously the more tests we do, the greater the number of infected individuals we'll find. But the key is to look at the rate of positive individuals who are tested, and that rate is continuing to decline. So that's actually a good sign. Ideally, we want to see the rate of positivity below 20%. We're actually seeing that rate about 15% now within our health system, as well as in certain areas within the city of Chicago. As the curve is flattening, the key is that we're not necessarily preventing additional infections, we're preventing a surge that would overwhelm the healthcare system. So flattening the curve is really advantageous, but we'd anticipate over time to see a reduction in the number of new infections.
Thank you. Howard, we know that there is asymptomatic carriage of the virus, and it raises the question of how effective screening procedures can be. Are there metrics that can reassure new or returning patients who need a procedure or need to continue their health care? Are there metrics that we can develop that patients will respond to in a positive way?
Thanks for that question, Eric. So I'd answer this in a couple ways. One is, as I spoke about a bit earlier, as we think about patients entering our environment, we do have screening processes in place for those patients who may or be asymptomatic, but we can detect. So as an example, we've had patients who have been asymptomatic, but when they come through, we're able through temperature screening to detect this. So 100% of all individuals that enter our environment are screened for both temperature, for any other symptoms that they may not actually recognize as being part of the symptomatology and any contact. We do the same thing for our employees. And then importantly, as we think about reinstituting elective procedures or those procedures for patients, we are testing them. So most recently, we began testing patients 72 hours before their arrival. And as an example, 7% of them that were asymptomatic were actually detected as having a viral presence. And so therefore increases our comfort level that we can treat them appropriately. Thank you.
Great. Rich, there is a lot of concern about how quickly the virus, the vaccine procedures can move forward and move forward safely. Some people worry that people will get vaccinated in these test trials, but there won't be a lot of contact with patients who have it or people who have it. And so the frequency of detecting a good vaccine might be affected. Will we be using any of the human challenge trials to speed up vaccine testing? Is that something that people are talking about?
Yes, there's a lot of discussion of that. It's still very controversial. The alternative to that is to test in frontline workers or in congregate settings in places where there's still a high risk, but that takes time. And, the argument for challenges is you'll know if someone's protected in 2 to 4 weeks instead of having to wait months for a large trial. And some very senior vaccinologists have proposed this, and Representative Foster from Illinois and Representative Shalala have been pushing for Congress to provide some cover for the FDA to allow the FDA to consider this if it turns out to be a useful approach. And, the arguments I think are strong, but it would be better, I think, if we had an antibody like a monoclonal antibody that could neutralize the virus, or a drug that was very effective that we could use in case a challenged person got very ill, because that's the whole point of testing. We don't know that they're going to be protected. So I'm hopeful that if we move to the point of trying a challenge, that we'll have a way to rescue someone if they get in trouble.
Thank you. One of the questions is, what is this new illness occurring in children during COVID-19? Maybe I'll try and answer that. As you know, most children, certainly very young children, don't seem to get the classic respiratory disease from COVID-19. But in the last 6 to 8 weeks, we've seen an increase in the number of children who are getting what the CDC now calls a multi-system inflammatory syndrome. Some people have called it Kawasaki's disease, which is an illness that has been around for decades, that intermittently occurs in children during transmissible episodes of epidemic. The epidemiology seems to map to some kind of pathogen that is shared in the community, and these people, these young children get an inflammation of the blood vessels. You get cardiac symptoms from myocarditis or inflammation of the heart. And these are largely viewed as autoimmune type responses to exposure to the virus. And it turns out today we're seeing a little bit more of that than is typical in the normal environment. And there is a suspicion that the COVID-19 vector, the SARS-2, is perhaps stimulating some of that in certain individuals who have the propensity to create that inflammatory response. Maybe we can go back to Gary. Gary, what do we know about reinfection rates once infected? Am I going to get it again? We see this in the literature, people talking about, I had it and now I got it again.
Yeah, so thanks. That's a really important question. I want to emphasize again, this is a novel coronavirus. So there's a lot of things that we still don't know. It may be similar to other coronaviruses. It may be similar to other viruses. It may be totally novel. And that's why some of the comments that you made are really important. Because if we check for antibody and someone has an antibody, does that suggest they can get reinfected or not? Is that an immunity passport, if you will? Or does that just suggest that they've been previously infected? So right now, there's at least some evidence that people can get reinfected, but it's hard to know whether it's due to the same novel coronavirus or other viruses. So as I said in my introductory comments, there's still a lot to learn about this organism.
Great. Howard, another question. Why are we seeing a predominance of hospitalization from the minority community, particularly in big cities, but Chicago is certainly one?
Thanks for the question. I think this is a critically important question and observation. And I think there are a number of factors that have led to this during this outbreak. One is in general, many of these populations, these individuals live in conditions or at home, which have denser populations. So as we know, the idea of physical distancing is not as easy to do when you're living in a denser population environment. Oftentimes work circumstances don't necessarily allow them to either work from home or do the things that might create physical distancing and separation. Education around what are the things that we need to do to help, as Gary mentioned, the 5 different steps that we can take. And I think also one thing that we recognize is that the mortality associated with this is aligned with underlying healthcare issues. So increased incidences, for example, cardiovascular disease in certain of these populations has resulted in a higher mortality in these groups. So I think those things, living conditions, work environment, and then underlying healthcare conditions have led to this issue.
Thank you. Rich, given now that there's sort of an anti-vaxxer community in this country, and there's a conversation about whether people will want to get vaccinated once there's a good vaccine, isn't there going to be a problem that everyone might not want to take it, and that might reduce the herd immunity?
Yeah, it's a worry. I do think it's a different situation now, though, and my feeling is at least the majority of the population are going to want a vaccine, and if that induces good protection, and if natural infection induces good protection, and we add those 2 proportions together, what we think we need to do is to get to 60 to 80% of the population having protective immunity. So if we can do that through a combination of those who are already or soon to be infected, plus those who get vaccinated, that may be enough.
And how do there are different requirements for herd immunity in different viruses. How do we calculate that? Because the reproduction number for COVID seems to be not as great as we once thought, so the amount of herd immunity might be less.
Yeah, it's a work in progress, but the reproductive number, also called R0, is a measure of how much a virus or any pathogen spreads when everybody in the population is susceptible. And if the number is 1, then the epidemic is stable, it doesn't increase. If the number is less than 1, the epidemic won't take off, it'll go down. And if it's greater than 1, you get a climbing curve. And for SARS-CoV-2, it's been estimated to be between 3 and 6. And we don't have enough testing to really be 100% sure of what the right number is. But if it's at that higher end of the scale, you need about 80% of the population to have herd immunity. If it's at the lower end, 60% might be enough. And just to put it in a frame of reference, measles has an R0 of 18. So measles is quite a bit more infectious, spreads quite a bit more, and we have controlled that.
Great, thank you. Gary, maybe you could talk about what kind of recommendations would you make to the state of Illinois regarding reopening, weighing the fact that hospitalization rates are on the decline and the ongoing impact on the state's economy? What kind of conversations are happening in that regard?
So not surprisingly, there's a lot of conversation at the local and state level on what it's going to take to move from the current phase 2 of the plateau phase to phase 3, which is a way to start to reopen the economy. What's really important is that we can control the infection and have enough capacity to care for individuals who are infected. Currently within the city of Chicago, we have enough hospital beds, we have enough ICU beds, and we have enough ventilators. So my suspicion is based on our capacity within Chicago, as well as what's happening with the epidemiology, we'll be able to move to the next phase in a couple of weeks.
Howard, what is your take on how the health systems are engaging with each other in the city of Chicago and working together and trying to provide a unified comfort level for the citizens of Cook County?
Thanks for that question, Eric. You know, my observations has been that there's been unprecedented collaboration and collegiality amongst the healthcare systems, our academic medical centers, and other partners within healthcare to help us through this. I think there's recognition that we are all in this together. And so in my experiences of being in Chicago, I think this is an unprecedented time of collaboration and cooperation. I also think there's been support and collegiality with our colleagues within the city, the state, and federal government. So my experience has been, as we think about both our response to the pandemic, but also reactivation about taking care of patients, the degree of collegiality and collaboration has been terrific.
Good, thank you. Rich, what is the risk of a significant mutation in the virus? And if this can happen, how does that change the vaccine approach that people are betting on?
Yeah, we're a little bit lucky on that score. This virus is really unusual in having what's called proofreading. When it makes copies of its genetic material, it actually makes an enzyme that edits that to take out any mistakes. So it makes many, many fewer mutations than a virus like HIV, which is at the opposite end of the spectrum. And influenza is sort of in between them. But given that, it's highly likely that whatever vaccine is developed today is probably going to stay useful for a prolonged period of time. I can't guarantee it'll be forever, but it's not going to be like influenza where we have to change every year. And it doesn't have the same daunting problems that HIV brings, where we can't get to a vaccine because there are so many different variants out there. So hopefully it will stay that way. You know, there have been mutations that have been noted as the virus spread around the world. And right now, we don't think they make any real difference in how the virus behaves, but that's being carefully studied. But it has already enabled epidemiologists to track the virus. And so scientists here in Chicago have determined that we got a virus from China, not via the West Coast, but directly from China, and also have viruses that came to us from the New York area by way of Europe. So we're relatively unique. The East Coast has more of the European virus, and the West more of the Chinese virus, and we have a mix. But we don't think that has any real clinical consequence yet.
Okay. Gary, as you know, the 6-foot social distancing rule was created without a mask on. And there's a lot of comment in the community as to whether it really has to be 6 feet if people are wearing a mask. And there's some people even debating whether that can be different in different communities and in different households. What is your current view of that?
So I think it's worthwhile just to remind the audience the purpose of the mask. The purpose of a mask in the external environment is to prevent someone who has asymptomatic colonization with the virus, or actually may be infected, from transmitting it to someone else or putting the virus in the environment. Now, that's in contrast to healthcare workers who are caring for patients with COVID. The masks that we wear protect us from acquiring the infection. So the reason to wear a mask is to cover your nose and mouth and to prevent you from putting the virus in the community. If you can maintain a physical distance of at least 6 feet, that theoretically can prevent you from getting the infection. But what's also important is not only is it the physical distance, but the virus can be on an environmental surface. You may touch that environmental surface and then touch your face or your mouth and then acquire the infection that way. So that's why I alluded to in my comments the real importance of the mask to help prevent someone who does not have symptoms from transmitting it to someone else or the environment, to maintain the physical distance of at least 6 feet, to wash your hands frequently, to avoid touching your face, and then to properly clean and disinfect surfaces that are commonly touched.
Okay. Now we have a question for all the panelists. Would you send your son or daughter to college this fall? And of course, my children, if they were at home, would be begging to go to college to get away from me. But there are some of you who have children in college age. Maybe we can start with Howard. What advice are you giving and taking?
So for those of you that know me, I have 3 that are in that era, that age group. And I actually believe that I would send all 3. You know, I trust in the leadership of the universities that they're going to and our capabilities to treat these young people. And assuming we adopt many of the sort of approaches that we have, as Gary mentioned, my sense would be that I'd be comfortable sending my children to college.
Gary?
Yeah, I want to echo what Howard said, is I would not be concerned about sending my son or daughter to college. Individuals between the age of 18 to 22, if they did get infected, would be at low risk for any serious complications unless they had an abnormal immune system. And I think the other thing that's really important is that if they do get infected, they do have the capability to get healthcare. So if they're in a community that does have great access to healthcare, I would have no concerns.
Rich?
Well, my daughter's a little bit older and she's in medical school at another university, and she's still there and dying to get back to in-person classes. And she practices everything that Gary was preaching really well. So I have no qualms. I agree with what my colleagues have said, that it's really important to follow all those procedures. I do think education is critical. So for students who are returning to campus or going to campus for the first time, I think we'll see all universities doing this. They probably need to get some training and maybe periodic retraining in those principles that Gary outlined to stay safe.
Howard, any thoughts on whether the warmer temperatures and sunshine will diminish the virus? What is the current social thinking around being separated from our surrounding friends and neighbors?
I've talked with Gary a little bit on this. You know, I think as we are able to go outside and have more physical distancing, the warmth and actually the humidity, I think, would help us sort of maybe manage the virus. We do know in drier climates, as the mucosa dries, the entrance of the virus might be enhanced in that sort of drier environment. So as we think about sort of the fall and winter months, the risk of surge. But I do believe that hopefully, maybe it's just sort of trying to be the world's half full, that the humid and warmer temperatures and being outside would hopefully diminish the incidence of the virus.
There's a lot of community discussion about immune systems weakening due to the prolonged stay at home, and the protocols that we've been living under. Is there any validity to these concerns, Rich?
I think that's a concern for young children, maybe, who for a long time don't get exposed to microbes. But an adult immune system is already trained from that earlier experience. So I don't think it would make a big difference for anybody older than a few years old.
Okay. Gary, can you comment on some of the claims made about COVID-19 by Dr. Erickson and Mikovits and Cahill and others, who seem to imply that the country's approach to this disease is all wrong?
I think like all viruses, like all infections and all pandemics, there's always discrepancy in what people think is correct and the best approach. And a lot is a philosophical discussion. From our country's perspective, and certainly from the city of Chicago and the state of Illinois perspective, the goal was not to overwhelm the healthcare system. So that was the purpose of having the executive orders that would require people to stay at home. I think largely that's really been successful. Unfortunately, the downside of that, it does have a deleterious effect on the economy. So a lot of it is a philosophical discussion, but I think what we can say comfortably is, at least within the city of Chicago and the state of Illinois, we've been effectively able to manage this pandemic based on the information that we have.
Howard, is there anything that business leaders can do beyond encouraging social isolation, conducting hyper-sanitation and cleaning of the premises, and educating employees? Is there any other activity that they can do to help the city of Chicago?
You know, I think, creating a safe and trusted environment through everything that you referenced is critical, so that employees can return to work feeling that comfort. I also know that there are other issues that we've addressed as a city, thinking about transportation and childcare and the overall emotional well-being. So I think looking at this holistically, that we're all in this together, will be critically important as we move forward in the next few weeks and months.
Gary, we know that state of Illinois has a lot of privacy protections around collecting health data. There's PIPA and BIPA and all of these legislative acts. Will these impede the implementation of contact tracing? And how do you balance the public health wellness issues with personal private security?
Yeah, thanks for that question. It's really important. In order to effectively manage this pandemic, we talk about testing, tracing, and treatment. So I did talk a little bit about the testing and the treatment. I didn't really mention much about contact tracing. And contact tracing goes back over 100 years. And it was a way that we could control the spread of tuberculosis and smallpox. And then more recently, that's what we do to control sexually transmitted infections, Ebola, measles, as Rich alluded to. And the way that contact tracing works is someone from the health department identifies an individual who's got a positive infection and then goes out and speaks with them to discuss who were they in contact with. Those individuals who are infected get put in isolation, all of their contacts get quarantined. So the methodology works, and it's actually very successful. Where the potential challenges are is, as you alluded to, Dr. Neilson, the concerns of privacy, and how do we think about individuals who may not be able to isolate? They may have medical issues, they may have other concerns, social or cultural, that may prevent them from doing it. So that's where the balance is, and that's where the struggle will be. But if we can effectively identify those who are infected, properly isolate them and quarantine their contacts, we'll be really successful in controlling this pandemic.
Donna, did you want to ask a question? Or?
I did. First of all, I just want to say thank you. This has been a very insightful and informative and pragmatic conversation. So really appreciate the time. I had a final question for each of you, including you, Dr. Neilson, and that is that with all the challenges that you faced and as a result of this pandemic, each of you have different perspectives, but can you share with us what gives you hope?
Well, maybe I'll start. I think hope comes from the working with high quality people and a community that's dedicated to making a difference. At Northwestern, we have heroic clinicians and fabulous scientists working on important problems around COVID-19. And with that kind of effort multiplied over many institutions all across the country, I have every reason to believe that we have a very optimistic future in solving this problem.
Thank you. And others?
Gary?
Gary?
Thanks. That's really a great question. And one of the things that I would say that gives me an incredible amount of hope is if you think of what we've accomplished and what we've learned over a period of basically 8 to 10 weeks, it's nothing short of spectacular. And it's a true testament to the leadership within our medical and social communities here within the city of Chicago and the state of Illinois. And it's our ability to collaborate, which is really unprecedented. I think the other thing that gives me hope is that on the back end of this pandemic, we're going to be far better, in at least at Northwestern Medicine, a far stronger healthcare system. There's going to be a lot of great advances that come out of this. I think one that Howard alluded to is the rapid advance of telehealth. I think outside of healthcare, you're going to see a lot more people telecommuting, working remotely, collaborating. So I am incredibly optimistic that once the pandemic resolves, we're going to have a great deal of successes to talk about.
Thank you, Gary.
Well, I'll just chime in that on the science side, I completely agree with what everyone else is saying. The teamwork has been astonishing. 2 weeks ago, there were 15,000 peer-reviewed articles on this virus. That's just in weeks. And that doesn't count all the preprints, which come out, hundreds every day. So scientists are working in teams spanning states and countries and making big, important discoveries every day.
And Howard, last word goes to you.
Thank you. I would echo what Gary said. As I walk the hallways of our healthcare delivery environments, our hospitals and our clinics, the spirit of the individuals, the support they have of each other, the story that I read about the nurses supporting each other has been nothing short of amazing to me. In every situation that you've asked for someone's help, they have said yes. There's never been a point in time where someone hasn't raised a hand to volunteer, to help out in every situation. And the pace of discovery and the pace of problem solving is so far faster than anything I've experienced that, as Gary said, I believe on the back end, we'll be so much stronger as a healthcare delivery system, as individuals, as a country. And so I have great optimism as we look forward and we successfully sort of begin our new phase of resiliency.
Thank you very much. And thank you all for taking the time to be with us today, as well as your leadership in the Chicago community. As we mentioned earlier, a recording of this program will be available on the YouTube channel shortly. So please feel free to share this video with your networks of colleagues. And to our members, we are always interested in your feedback, and we'll be sending you a survey after this program. And finally, to all, please stay safe and remember that we can each do our part to help out these wonderful healthcare heroes, professionals, first responders, and all those that are still working very hard on our behalf on the front lines of this pandemic. So thank you and have a wonderful day.